Hello and welcome to Learn from the Case. How are you? Today I want to talk about rheumatic fever. Myxomatous degeneration of mitral valve or mitral prolapse and chronic rheumatic fever are two chronic valve pathologies that are remembered almost exclusively when they become complicated. Otherwise, they go largely unnoticed. Rheumatic fever is claimed by some to not longer exist. So, rheumatic fever, this pathology, is almost not seen anymore. Personally, I have never seen it in any of my patients. And well, that may not be saying so much, but I have asked many colleagues in different countries, including specialist cardiologists, and no one has seen it. I have been told that in the last 50 years has not been seen. But it is fairly well described pathology, and it is something that must be recognized because it can happen that someone appears with this disease. It is a disease that occurs due to a hypersensitivity reaction triggered by group A or beta hemolytic streptococci. It is argued that antibodies directed against M proteins of certain strains of streptococci give rise to cross-reaction with glycoproteins in the heart, joints, and other tissues. Or more simply, that streptococcal infection awakens an autoimmune reaction in the patient. But even when it was more common to see, this disease was only found in 3% of people who were diagnosed with this streptococcal infection after having had the infection. So it has been suspected that there must be some component inherent to the patient or a specific situation that favors the development of the pathology, such as a genetic susceptibility, immunological or environmental conditions just at the right time to be able to develop this disease. It is described that 2 to 3 weeks later, or sometimes it is say 10 days to 6 weeks later after the throat infection, symptoms begin, although sometimes they do not lead to the patient seeking medical help. In patients with rheumatic heart disease, the mitral valve is the most frequently affected, and the mitral valve is affected exclusively in 65 to 70% of cases, and the mitral valve with the aortic valve in 25% of cases. A fish mouth or buttonhole stenosis occurs in the valve. This causes the left atrium to empty with difficulty and dilate increasingly, and may harbor moral thrombi in its appendage or wall. As many of you already know, rheumatic fever is characterized by a set of manifestations that are migratory polyarthritis of the large joints, carditis, subcutaneous nodules, skin erythema, and Sydenham chorea. So these manifestations are used to diagnose this disease. These are the so-called major joints criteria. Clinically, arthritis and carditis stand out, the first being more common in adults and the second in children. Murmurs, typical of endocarditis of all types, in rheumatic fever are described as dull head tones. In addition, it is common to find tachycardias and other arrhythmias. In the acute phase of rheumatic fever, widely disseminated inflammatory lesions are seen. In the head, aqueous bodies are seen. Foci of fibrinoid degeneration surrounded by lymphocytes mainly T lymphocytes, as well as swollen macrophages, affectionately called Anichko cells, pathognomonic of rheumatic fever. These aqueous bodies can occur in any part of the heart, pericardium, myocardium, and endocardium. That is why it is said that it can cause pancreatitis. The vegetation are small, 1 to 2 millimeters, arranged along the closing edges. Subendocardial lesions, perhaps exacerbated by jets of regurgitation, can cause irregular thickening called McCallum plaques, usually located in the left atrium. Throat cultures are negative in rheumatic fever when rheumatic fever appears, but antibodies against one or more streptococcal enzymes might be found in the serum, such as streptolysin O and DNase B. After the first episode of rheumatic fever, it is easier for the process to be reactivated, causing new episodes after pharyngeal infections. Chronic rheumatic fever disease is usually asymptomatic for years or decades. The most important consequence of rheumatic fever is chronic rheumatic heart disease, which is characterized by fibrous and deforming lesions of the valves, especially stenosis of the mitral valve. This can lead sometimes decades later to permanent functional disorders and severe and sometimes fatal heart failure. Well, this whole video arose from the fact that I kept thinking about the infrequency of rheumatic fever and that neither I nor one of the colleagues I asked have seen a case of this. And then I started searching for clinical cases on the internet and I found many. Unfortunately, they do not indicate how old they are. They could well be from many decades ago. But anyway, I found it interesting. I want to emphasize that this article describes a case and has a publication date, but it is not the date of presentation of the case. I do not find any current cases of rheumatic fever. This even when I looked for other forms of presentation using the Mayer-Jans criteria. Chorea minor or Sydenham's chorea seems to still be present in cases that appear very sporadically. It is considered a late manifestation of rheumatic fever, with an interval of 1 to 6 months. It affects girls closer to adolescence more, and sometimes it can be the only presentation of the disease. Clinically, it presents with uncoordinated movements, grimaces, irritability, easy crying, and character alterations. The actions of daily life that require coordination are clumsy. The lesion is located in the inhibitory center of the extrapyramidal system. Its frequency is less than 2%. Apparently, 25% of chorea cases are affected by carditis. This Sydenham chorea is a very rare disease in the United Kingdom and Ireland, but it has not disappeared, according to this article. See the description of this video to reach all the links. They say here, our findings emphasize the impact the condition can have in children's functioning and confirm that pediatricians and child psychiatrists should remain alert to its present characteristics, which commonly include emotional and behavioral symptoms. It is also necessary to reach a consensus around identification, diagnosis, and treatment in all child health settings. It is also very strange, you see, if the rheumatic fever was only seen in 3% of the cases with pharyngitis due specifically to Streptococcus pyogenes, and only 2% of that 3% will develop Sydenham chorea. Imagine how many times in his or her professional life a doctor will see a case of this, and that when rheumatic fever was still common. Subcutaneous nodules, also called Maynard nodules, are tumors. Those are hard, painless, between the site of a pea and an olive that do not adhere to the skin, located on the elbows, knees, and neck. They are very rare, 10%, and are also associated with severe carditis. But these same nodules, so they do not adhere to the skin, are not painful without an epidermal component located in the extremities, which histologically present sarcoid granulomas in the subcutaneous cellular tissue, which are more frequently seen in the ankles, are more associated with sarcoidosis. Currently, it has always been known that a percentage of patients with sarcoidosis, 25% according to some data, may present with dermatological symptoms, and maybe the appearance of subcutaneous nodules with that description. Diarrhea-erosive sarcoidosis is called. Other causes for subcutaneous nodules, other than rheumatic fever or sarcoidosis, are also associated with less common conditions such as pancreatic carcinoma or siliconomas, which are subcutaneous nodules that appear as a consequence of the migration of silicone implanted in other locations, more common in people with abnormal breast implants, such as polyimplants prostheses, but they can also appear after an illegal injection of free silicone. And in these patients, subcutaneous nodules can appear anywhere on the body, not only in the thorax. They can appear, for instance, on the face. Skin erythema, or erythema marginatum, is an evanescent macular eruption, rounded reddish spots that can join together and form larger lesions. They do not cause itching or pain. They appear mainly on the trunk and have a migratory pattern, which means that they can change their place of appearance. It was described as rare when it appeared, when rheumatic fever was more common, and was seen in acute rheumatic fever. Of all the clinical manifestations, this is the least pathognomonic. A lot of cutaneous and non-cutaneous conditions can manifest like this. Without going any further, scarlet fever can sometimes imitate that. And since this is a major criteria of rheumatic fever, that is, since when rheumatic fever begins to manifest, it can overlap with the scarlet fever. That is also seen with throat infections. And well, as I say, I have never seen a patient with rheumatic fever, but of all the criteria, this is the least specific. Of course, since it appeared early, it was important to suspect it, and it remains clear in case more people with rheumatic fever eventually appear. And for migratory polyarthritis of large joints, well, there are many differential diagnoses that are much more frequent than rheumatic fever. Almost one does not even think about rheumatic fever. Of course, one thinks about viral arthralgias when the joint symptoms are new, adverse effects of medications such as statins, some antibiotics. Look at this article, for example. Mechanical overuse, gout, chondrocalcinosis, rheumatic diseases with periodic manifestations or onsets of rheumatic conditions, sarcoidosis here also. So it is not at all easy to find a case of rheumatic fever, but let's not forget the peculiarities of this disease so we don't miss a patient with it if one appears. Therefore, it is advisable to remember all the criteria and features from time to time so we stay alert. And with this last thing, I say goodbye today. As always, you're welcome to leave me your comments or questions. Thank you for the attention and be very, very well.